one of the things I like about my position is that not only do I do ECT, electroconvulsive therapy, but I'm also the director of our bipolar program. So I really get, I think, a good sense of how ECT can be used in depression, not only of unipolar depression, but for people with bipolar disorder who are depressed as well. So let me just get started, and this is my introductory slide. Everyone has should be able to see my name, and you have my email address for future reference. The picture in the upper left-hand corner is one of the street view of our the Langley Porter Psychiatric Institute, which is where I work and where I am at right now. I don't think you can see my office window. I'm a little bit in the back, but I'm on the second floor. So this is an outline of the talk, and I'll show this slide as we move forward just to keep people oriented to where I'm at in my talk. So I'm going to talk about the history and legal issues of ECT, which is a really interesting and fascinating area in and of itself, but I won't spend too much time on it, but a few slides on that. Then I'll talk about efficacy, which is how well ECT works. Then the very important issue of the side effects of ECT, which would include, which many people are interested in, is how much memory problems does it cause, amnesia. Finally, I'll say a few words about how it works and what we know about ECT. And then I'll talk a little bit about the practicalities of the treatment and just kind of give an overview of what treatment might look like for a potential person who's interested in ECT. And then I'll try to summarize a little bit at the end. So first, history and legal issues. This is a picture of Ladislav Meduna in 1932. In 1932, he observed cell overgrowth and undergrowth in brains of patients. And what he found was that individuals who were diagnosed with schizophrenia, he saw that the cells, the neurons, the cells in the brain, did not grow very much. There was undergrowth. And then he saw that individuals who had epilepsy had overgrowth, and patients who had epilepsy did not have schizophrenia by and large. So the idea was at that time was to see if maybe somehow seizures were protective against schizophrenia. So in 1933, he embarked on some animal trials to find a medication that could actually induce seizures. And then in 1934, they settled upon using camphor to induce seizures in human beings. And they were very fortunate that the first humans that they actually tried these medications actually probably did not have what we would call today schizophrenia, but probably had more of a bipolar disorder. Then in 1934, camphor had a lot of problems. It's inhaled. They found an injectable medication called, which I'm not sure I can pronounce, but pentylethotetrazole, also known as metrozole. And in 1938, this guy, the picture on the right here is Ugo Cerletti and his colleague Bini. In Italy, they were triggering seizures in people using medications, but he was walking by a slaughterhouse for pigs, I believe, and he noticed that they would use electric prods to stun the animals before they would slaughter them. And he noticed that it often might trigger a seizure in the pig, and it never killed them. So contrary to what people usually think of when we think of the electric chair as using a lot of electricity to kill someone, in this situation, he noticed that it actually didn't kill the pig, but it did stun them, and in many instances, it triggered a seizure. So he thought, oh, maybe we can use electricity to trigger seizures. And they were successful. And then in 1940, this doctor named Lothar Kalinowski brought ECT to the United States. So just a couple of years after that, and it became very popular after that. Let me just go back a minute. Just one comment about these individuals. I think part of why ECT gets a bad rap is because these guys are kind of weird looking, to be quite honest, but that's just my own opinion. I like to give pictures of where we work when I talk with our potential patients. So this is a picture of the outside of the ambulatory surgery center, which is where we do the ECT. And I'll have some of these pictures interspersed with the presentation so you can get a sense of what it looks like. The usual perception of where ECT is done is usually like in a dungeon, and I like to show that we actually have a nice surgery center, and we happen to get San Francisco on a sunny day. It's often very foggy here, as many of you know. Now, just back to electroconvulsive therapy. And actually, about 50,000 people receive ECT each year in the United States. And actually, it turns out the number of ECT procedures performed in the United States exceeds the number of coronary bypasses, the number of appendectomies, or the number of hernia repairs. So people are not often aware of how common the procedure really is. Now, part of the issue is that 50,000 people, each one, as I'll talk about in a little bit, each one of these 50,000 people on average gets 8 or 10 treatments. So that adds up to a lot of procedures per se. Like when you get a coronary artery bypass, hopefully you're only getting one of those, and certainly an appendectomy, each person can only get one. This is a picture from our waiting room in 2004 in the ambulatory ASC, we call the Ambulatory Surgery Center, from 2004. So I actually have been there for almost 10 years now. Let me give you a little bit of history of the legal issues in the state of California. I don't know how many people, how many listeners are from California. It'd be kind of nice to know. There's a lot of history with ECT and stigma related to ECT. In 1977, there was an Assembly Bill 4481 that severely restricted the use of ECT in California. Now, that actually, let me just go back. That was actually overturned, and it's now governed by less restrictive use by Bill 1032, which is still in effect. And I'll go into a little bit about what Bill 1032 says here in California. Now, many people have asked me, isn't it illegal to perform ECT? In 1982, so people who are older may recall that Berkeley did pass a referendum making administration of ECT punishable, not by death, but punishable by, I think, a 6-month imprisonment or a $500 fine or something like that. And it turns out that you can't, that was overturned by the Supreme Court of California because you can't, legislate medical procedures like that. You can't just ban appendectomies, for example. Similarly, in 1991, San Francisco Board of Supervisors passed a resolution against the use or financing of ECT. It doesn't have much legal weight. It's kind of one of those, this is our opinion, we don't like ECT kind of thing. But now it is now 2013, and I don't have another a bullet point on this, but ECT is, I wouldn't say super common here in San Francisco, but we do it, and we have a moderately busy service, I would say. We're a small service, but we're pretty busy all the time. I guess that would be the other way to put it. Now, so what does Bill 1032 entail, which I mentioned a little bit earlier? It means, it states and stipulates that in order to obtain informed consent, so any surgical or medical procedure you need to get one needs to get informed consent, and it requires the documentation by 2 board-certified psychiatrists or neurologists every 30 days. So we have to document every 30 days that this person is capable of giving informed consent for ECT, meaning they understand and they're able to understand why they're getting ECT and also the downsides of ECT. And that has to be done by 2 board-certified psychiatrists, one of which cannot be me or the other treating psychiatrist. So meaning there has to be one outside psychiatrist who's signing an affidavit basically says this person is competent to give consent and ECT is also indicated, meaning it's a useful and medically necessary procedure at this point. We can't just meet someone on the street and give ECT right away. The state law says we have to explain and meet with the patient at least 24 hours before the consent form can be signed. So that means patients have at least 24 hours to think about it, talk to family members, and so forth. In actual practice, it's usually we can't get people in that quickly into our service. We have to meet someone like a week or 2 in advance, and then by the time we get all the consent forms and the as you'll see, logistical things taken care of, they wouldn't be able to get the procedure anyway. So 24, this is not that significant for us in general. And then family must be notified, or notification of the family must be specifically rejected by the patient. Patients are informed that their family members can be notified. They should be notified. I love to meet with family members when individuals are getting ECT, because a lot of times the family has to be the people who pick them up from the ambulatory surgical center, or they just should know about it so they can help out with and support the individual while they're getting the treatment. I think the last rule was probably mostly having to do with when individuals were far away at state hospitals. So someone from, say, Monterey, California might be hospitalized in Napa State Hospital, and their families wouldn't know that they're getting this procedure. So they have this item in the law just to make sure that family members know about the procedure. And it's actually explicitly illegal for us to treat minors less than 12. That very rarely comes into play, except in one very unusual circumstance, which I'll mention in a little bit. This is a picture of the post-op area, so you can just see it's a typical post-op area for anesthesia. And actually, all the other outpatient procedures are occurring here also. So people who are getting, things done, cataract surgeries or things like that after they get their procedures, they'll come into one of these little bays here and recuperate. So let me, I'm going to give people a chance if they have any questions to jot them down, but I'll answer them again at the end. And unless there's a huge number, Ashley, in which case maybe I'll give it a shot in between, but I'd like to just move ahead with the efficacy.
Yes, go ahead.
Okay. So now, how effective is ECT? Well, first of all, let's talk about what do we use it for. So in medicine, when we say indications, what do we use ECT for? The most common reason is for a major depressive episode. So it could be of either unipolar or bipolar disorder. So far and away, 95% or plus of the individuals we treat are suffering from a depressive episode. Occasionally, patients who are acutely manic or have schizophrenia are treated with ECT. There's less information about these two conditions and ECT, and we have other medications that tend to work a little bit better, so we don't, it's less common. And then rarely, patients who have Parkinson's disease or neuroleptic malignant syndrome or intractable epilepsy, also known as status epilepticus, we will treat with ECT. I think we've had about 3 patients in the past 6 years who we've treated with, say, status epilepticus or intractable epilepsy with the ECT, and oftentimes we're kind of called in at the very last resort. But I think 2 out of the 3 we had a pretty good, we were able to help out. 1, it was kind of too late, I think. And then we don't usually do it for Parkinson's disease directly, but a lot of times many of our patients are older. They will have Parkinson's disease, which is a very common disorder. And it's interesting that the Parkinson's disease sometimes is helped by the ECT as well as the depression. So it's kind of just an interesting observation. Now, we don't do it for everyone who has depression. What do we do it for? So in the most common reason is patients who have tried lots of different treatments already, and what the situation is called treatment resistance. So I'd say many of our patients have tried 6, 8, or 10 medications and they haven't worked, or they haven't been able to tolerate the medications. And then sometimes we'll do it when there's a need for rapid definitive treatment. The first individual is very psychotic, or they're catatonic, they're not able to eat, or they have severe weight loss, or they have severe suicidal ideation. So we need something that works right away. We know it will we know we're delivering the treatment. It's not a medication that the person may not absorb that well, and so forth. And finally, we have a lot of individuals who have had family members try it and have observed other people get it. We have a lot of healthcare professionals who have seen it work for other people, and they know it's going to help them, or they have a good sense that it's going to help them. It's very rare, even in that situation, that a person hasn't tried multiple other kinds of treatments before coming to us. But certainly some people come early to us than others. And then also high medical complexity. ECT is a highly regulated procedure. We have an anesthesiologist there, so if the person has other medical problems, sometimes medications can be more problematic, so ECT can be preferred in that situation. There are no absolute contraindications. Contraindications meaning reasons why you can't do ECT. Now, any medical condition let me just list the medical conditions that are associated with increased risk. That would include if you have an intracranial mass, like a tumor or brain tumor of some kind. Other things, if you had a recent myocardial infarction or a heart attack, pheochromocytoma, or anyone with a high anesthetic risk, because this is a procedure where the person is under general anesthesia, although it's very brief, and we don't use gas, it's an IV anesthetic, but it is considered general anesthesia. Now, finally, let me get to the question of how effective is it. There have been a lot of studies looking at ECT versus sham ECT, and the sham ECT, they would do everything except actually deliver the electricity. So the person would be put under general anesthesia and everything else, and then they would do. And those studies are a little bit older. We don't have those studies more recently just because they're very hard and expensive to do, to put someone under general anesthesia without doing the treatment. As well as we have a bunch of ECT versus medication studies. So I'll skim through those briefly in a moment. And it does seem to compare favorably with medication treatment of depression in general. And again, the efficacy is most clear in depression. This is a rather complicated chart. It's called a forest plot, which is what you see here on the right. And I'll spend a moment just to go through with this. You don't need to know the details, but each one of these lines here represents a study. You can see Steiner, 1978, and then the number of participants in the study. This study only had 12. And then as you go forward, you can see here, as you go to the right more, you can see here on this forest plot that these bars represent how confident they are in the study. So the wider the bar is, the less confident, the more variability in the findings. And if it's to the right, the study favored the medication arm, and if it's to the left, it's favored the ECT arm. So you can see in many of these studies, and there's, I don't know, 10 or 15 listed here, there's a couple that have some big number of participants. And so with those, it's more clearly to the left of this midline that favored ECT. And if you add up all these studies and took all the patients together, it looks like ECT does seem to be better than pharmacotherapy, which is another name for medications in these studies. So this is a big kind of overview of multiple different studies. More recent efficacy rates. This is just taking some some data information from 3 studies and looking at the remission rates. So the Columbia study from Columbia University, and this is a multi-site trial. I think they had about 10 different ECT centers. They had a remission rate of about 55%, and this number represents how many people remitted, and that means got really completely better from their depression, or as far as good as we can tell. They were completely remitted from depression. And this number represents the total number of people who got the ECT. And this does not include the number of people who maybe got better but didn't get all the way better. So, you know, we're still interested in getting people all the way better as the best thing. But still, remission rate is, I think, underestimating how much benefit the person can get from the treatment. So this one showed a 55% remission rate. And just, is 55% good? You know, we'd like it, of course, to be 100%. But compared to other treatments, it is pretty good, especially for something like treatment-resistant depression, because you have to remember these 290 people didn't come in as their first episode of depression. These were all treatment-resistant depression that tried multiple medications. The second study, the core study, which I think is centered at Duke University, again had multiple sites, I think at least 5. They had a much higher remission rate, 86%, probably having to do with how they picked their patients a little bit, but still a treatment-resistant population. And just to compare, this is the STAR-D study, which is a trial for medications, which looked at what was the remission rate after just medications. And these were all people who just came in, so that they were not necessarily treatment resistant. In some ways, quote, an easier population. They had a remission rate of only 67%, and that was after 4 medication trials, 4 different medications. You could get about 2/3 of the population remitted. So just to compare the different remission rates amongst the 3 different big studies. So now that's the kind of the big picture. Are there any factors that we can, when I see someone, I think of, oh, this is going to be especially good for this, ECT will be especially good for this person. Individuals who have catatonic features or who have psychotic features, who are, for example, delusionally depressed, it seems to work better for you. You might think, oh my God, the person's catatonic or they're psychotic, that would portend to be worse. But it probably selects for a certain kind of depression, maybe, you know, quote unquote more biological, that ECT works particularly well for. So when I see these things, rather than being bummed out myself that this person's so severely depressed, I'm actually kind of more positive. I'm like, oh, this is the perfect person for ECT. And of course, ECT, persons who have had ECT before and done really well with it, you know, there's the high likelihood they're going to, you know, do it well again, for example. And then there's been some interesting studies, and I have this in parentheses, about suicidal ideation or suicidal thinking. It turns out that if you just monitor people's suicidal thinking, people, you know, ruminating about dying or being better off dead, ECT seems to help with that. Even if the depression doesn't get better right away, the thinking about suicide seems to go away pretty rapidly. Now, these are some of the factors that I find are associated with variable response, like it doesn't work as well. Now, I have to say I've kind of given up on saying it won't work for you, because I've definitely been in the mode of like, oh, the person has had all these negative variables, but they still have done well. So these are factors against, and I try to be realistic with individuals, but it's hard for me. I've given up, like I said. I've had enough experience now, and I've said to people, oh, I don't think it's going to work. We've gone ahead and tried it, and lo and behold, it worked really great. So there you have my clinical judgment on some of these things. So patients who've been depressed for a really long time, and by depressed for a really long time, meaning years and years. I mean, everyone, when they come to see me when you're depressed, whenever anyone's depressed, you feel like you're depressed for your whole life. That's just the way you feel. But when you talk with people carefully, you can tell some people have been depressed for 2 or 3 years or less. to my mind, I know 2 years is a long time, and I wonder how people can make it that long. But from a psychiatric point of view, that is a relatively short period of time. So 2 years or less, if they've had a kind of an acute onset of depression, those things tend to be a better response than people who have been actually truly depressed since childhood and chronically depressed straightforward through the whole time. Medication refractoriness, meaning the more meds you've been on and have not worked, the less likely ECT is going to work. And that just makes sense in the sense that we're probably selecting for more challenging population. A relative lack of neurovegetative signs. So patients who have neurovegetative signs, meaning sleep or energy problems or thinking problems, concentration, that tends to be a better sign. If people seem to look okay, have been depressed for their whole lives and still kind of function, ECT doesn't make as much of a change in that situation. These comorbid substance abuse, maybe that goes without saying, but I still feel like it's important to say, if you're using cocaine regularly on a daily basis, ECT is not the treatment for you. It's just not going to work. We really want people to be clean and sober for several weeks before we do the ECT, just because of the complicating factors of using drugs and so forth. Comorbid personality disorder, that's also a relative contraindication. Like I said, there are many individuals who have personality disorders who are really depressed. It may help with the depression, may not help so much with the personality disorder, but people seem to behave and have much better attitude when they're not severely depressed. So even personality disorders can get, the person feels better, and some of the personality traits are ameliorated when they're not so depressed. Now, the other thing about ECT, when I talk about how effective it is, it doesn't cure depression. The person still has once the person who has had depression, has had severe depression and has responded to ECT, there is a risk of relapse. So what we want to do is make sure the person stays on some sort of medication to prevent relapse. Because it turns out that staying on medication really does reduce the rate of relapse. So in this study, they looked at relapse rates after 6 months. And so what happens if the person and this ECT was successful, after the ECT was successful and the person was just put on placebo, a sugar pill, they had an 84% chance of relapsing after 6 months. And you can see that even with medications, the Nortriptyline and lithium combination, there still was a pretty significant relapse rate. I would say that this relapse rate, although is significant, people are not as depressed when they relapse. They don't fall back quite as, they still can get quite depressed, by the way, but they don't fall back quite as badly. But it's very important that people know that it's not a cure. You're still at high risk for depression. You need to be on a medication afterwards. So I think of this as ECT needs to be part of an overall game plan. It's not like the treatment of last resort or anything like that. We have to make sure it makes sense in the overall game plan. We have a game plan for what's going to happen whether the ECT works or doesn't. I mean, we'll try it, but we need to make sure that it's part of the overall treatment plan. This is a summary of other trials. This middle one here is the Sackheim study that I just showed you. This other studies looked at other relapse rates. They were small. This one only had 87. This one only had 26. But they showed that after 6 months, if you're on Paxil, paroxetine, your relapse rate is only 10% in this study. And in this study, it was only 18% for imipramine. Now, a lot of times patients have been on Paxil or paroxetine, and it hasn't worked for their acute depression, but it turns out that if you're on a medication, it's much less likely to recur if you're on a medication, even if that medication didn't work in the first place. I like to think, I'll say a little bit more about why I think that occurs in a little bit. This is a picture of our treatment nurses who are really fantastic. It's really a team effort in the ambulatory surgical center. So what are the side effects? This is a topic that people are super interested in, and it is super important because there are some significant side effects with ECT, and it's not something we go into lightly. Now, is ECT safe overall? This is just one study looking at the mortality rate with ECT. They had over 8,000 patients who received 50,000 ECT treatments in this 5-year period. There were a total of 30 deaths reported to the mental health department. That sounds like a lot, but if you compare the 30 deaths with just childbirth, ECT is 10 times safer than childbirth, and just the 6 times more deaths are caused by lightning every year. And then just the spontaneous death rate for ECT is about 1/10 of the spontaneous death rate in the general population, corrected for age. So what that means is you're less likely to die as you're getting ECT than you were if you're just out and about in your regular life. Part of the issue is patients who are getting ECT are being monitored really closely by anesthesiologists during the procedure and in between the procedures, so your blood pressure is being controlled and all sorts of things. And if you really have some sort of terminal illness or really close to death, ECT may not be indicated in that situation anyway. So we don't have, the ECT is quite safe from a mortality point of view. No one dies of ECT per se. But there are adverse effects, and I'm going to list them here. There are headache, muscle aches, which is probably due to the muscle relaxant we give people, this post-treatment confusion, and sometimes some nausea. I don't have that listed up here. And then memory impairment. Now, I would have to say 1 and 2 and the nausea, headaches, muscle aches, and nausea, while they can be a problem, they're usually not what I would call deal breakers. They don't get the person, when you're severely depressed, you can put up with a headache or some muscle aches. It's the memory impairment that people are most worried about. There's a post-treatment confusion that can last for a while also. So right after the ECT, it can take people anywhere between half an hour to an hour to kind of get back to their usual self, just because they've had general anesthesia. They just had a seizure. Electroconvulsive therapy, we're using electricity to trigger a seizure. And so that takes a while to clear up. And as we do more, sometimes that kind of confusion can last for several hours or even a day or two or more. But it's not permanent. This kind of thing resolves after we stop the ECT, and it will get better. The thing that people are most concerned about is memory impairment. So let's go. So memory impairment. There has been research done on memory impairment. And 3 broad areas of ECT treatment are in the literature. And so there's one when the ECT was first introduced, 1938 to 1958. And in the old days, they did this thing called sine wave and bitemporal ECT. I won't talk about the details of the technique right now unless there's a question about it. But it wasn't until 1958 they was starting to use unilateral ECT, meaning just on one side of the head. And then in around 1980, towards the 1980, there's the adoption of brief pulse ECT. That's regulating the electrical current in ECT to deliver it in briefer, very short pulses that cause less memory problems. So basically, it's not until 1980 that the adoption of modern ECT has occurred. So basically, if you look at studies from 1 and 2, they're old studies, and they're basically not doing ECT the way we do it now. So when they're looking at memory problems, it's mostly for historical interest only. If you want to look at a study about memory impairment and ECT, you've got to look at how it's done, and probably 1980 till now is really when it's pretty much all the centers have been using modern ECT. Even like 1979, even 1980s, there were some centers that had the older forms of by sine wave ECT machines. But but pretty much by 1980, the vast majority of ECT centers were using modern ECT technique. Okay, so what about the memory impairment issue? Okay, so I have this question that have you ever experienced amnesia? Well, part of the problem is when we're trying to study ECT-related amnesia, we're all undergoing, or the vast majority of us, I believe, are undergoing a kind of a baseline rate of amnesia, like what did you have for breakfast last week? We can't remember these kinds of things. So we're all continuously forgetting things, basically. So how do we measure this with in this study? So let me go back. So how do we measure memory, and how do we think about memory? Now there's a little bit of a digression here, and I apologize for this. So, but I just want to discuss what memory is and how it works. So memory has several steps, it turns out. There's 3 steps. So one is laying down new memories, one is storing memories, and one is retrieving memories. So when patients are getting ECT, for example, they may be kind of confused, and they may have trouble with retrieving memories, but they still, or laying down memories, but the memories are still there. So later on, 2 hours later, when they wake, when they're more awake, everything may come back to them. Then they're not confused. They're able to now retrieve memories. You can even notice this yourself when, for example, you are waking up in the morning. You may not or took a nap. More likely when you wake up from a nap, what happened? There's a brief moment there where you're trying to figure out what's going on. You're retrieving memories. Now those memories are still there, but you're just still trying to retrieve them. So there are many types of memory, actually. So there isn't just one kind of memory. We like to think, okay, I told you my name, now you remember or you don't remember. There are many different types of memory, and it turns out that memory is actually affected most by ECT affects one kind of memory more than others. So types of memory, there's retrograde and anterograde amnesia. Retrograde meaning from a certain point and before. Anterograde means from a certain point going forward you'll have amnesia. There's long-term and short-term memory. Many of you may have heard of the term working memory and so forth. There's personal versus impersonal memory. And there's episodic versus semantic, and objective versus memory. And that metamemory, that's called. So every memory we have, we also have a confidence interval or sense of how good that memory is also. That's a judgment about how good our memory is. That's called metamemory. So when people are very depressed, their sense of their memory is horrible. For anyone who's been depressed or worked with people who are depressed, their memory is really bad to begin with. They don't focus. They have a lot of difficulty concentrating. So we're trying to separate ECT-related memory problems from depression-related problems. And traditionally, ECT is thought to cause the greatest deficits in autobiographical memory. Let me just try to consolidate all this kind of stuff that I just taught you in this little format here. Maybe I should have just shown you to begin with. So this is a chart of all the different kinds of memory. This is all the long-term memory we have. So when I ask you what was your birth date, or what's the, who's the president of the United States, that's a long-term memory. There's two kinds of long-term memories. One is non-declarative memory, and there's a bunch of these different kinds of things. So you learning how to golf or driving the car, that's all memory. That's stuff you learn, but it's non-declarative. Declarative memory is divided up into two parts, semantic memories and episodic memories. Semantic memory is like, who's the president? Tell me what the book of, Moby Dick says, kind of thing. That's semantic memory. Episodic memory is like these little narrative events we have in our lives, like a remembering of getting married or doing certain kinds of things that have a more autobiographical feel. This is also known as autobiographical memory, episodic memory, and this is the memory that is thought to be most sensitive to ECT-related amnesia. So that's a long way of saying this, but just to clarify what we're thinking about. This comes from a paper, this chart comes from a paper that started with this thing, but I kind of like this one better because there's a little picture for everyone to think about. So that's the main kind of memory problem that is affected by ECT. Now, there's another thing called Ribot's law, who noticed that amnesia is greater for recent compared with distantly remote events and for less salient events. So things that happened to you a long time ago, you're much more likely to remember than things that happened to you a week ago. And that's true of any kind of amnesia, not only ECT-related amnesia. But so things that happened to you more than a year ago, and if you remember them now, you'll probably remember them after ECT. Some of the things that happened more recently are less likely to be remembered. So, for example, Kitty Dukakis has written a book called Shock, where she describes some of her experiences with ECT. Overall, they were pretty favorable, I believe. But she did say that she had gone on a weekend trip with Michael Dukakis about 3 months before her ECT treatments. She did not remember them at all. So that's an example of something that happened pretty recently, much more likely to be forgotten. Ribot's law. Recent events are more likely to be forgotten than remote events. Now, it turns out that bilateral lead placement causes greater cognitive problems than unilateral. We have several studies looking at this. But bilateral, I think, works a little bit better. Usually, yeah. So we usually start with unilateral, and we'll switch to bilateral only if the unilateral doesn't seem to be working. Other places may start with the bilateral, thinking that, in general, you're going to cause, use less treatments of ECT, and that will help with cognitive issues, too. So fewer treatments will help also. So there's merit in both ways, I would say. But we tend to be a little bit more cautious and start with the unilateral unless the individual asks us to go ahead with the bilateral. This is just where we put the pads when we deliver the stimulus. So this is right unilateral, and bitemporal is one on each side. And bifrontal, we don't do that that much at our center, but at many other centers that are very cutting edge do it bifrontally. And that's probably causes intermediate amount of memory issues compared with this one and this one. And my sense is it's intermediately effective as well between this one and this one. It's quite effective, by the way. Some of the things that make post-ictal, meaning post-ECT or post-seizure confusion worse, and these are a whole bunch of things I don't want to bore you with, basically, but the more treatments you get, the more likely you are to be confused. When you're in a confusional state after the ECT, it's very difficult to lay down memories during that time. So anytime you're super confused, it's harder to lay down memories. Remember, memory has 3 parts: laying down the memories, storing them, and then retrieving them. It can be hard to lay down memories when you're in a acute confusional state. When patients are psychotic, they can't lay down memories. Certain medications can't. People have trouble laying down memories, like benzodiazepines can affect that. Alcohol, and when people have alcoholic blackouts, for example, they can talk, they're having a great time, for example, but they don't remember it. That's a good example. If they're able to store their memories, they're able to retrieve them, but they're not laying down any new memories. Another example is a football player gets his, quote, bell rung, gets hit on the head, still goes out, plays the rest of the game, but can't remember playing what happened at all. They were in a kind of a confusional state. They weren't able to lay down new memories. Hope that's clear. So patients can have this spaciness, which can last for several days to a couple of weeks sometimes after the ECT, and during that time they may be having trouble laying down memories. This is a graph of the kinds of memories that are studied, and these are different kinds of memory tests here across the bottom. This is looking at different kinds of ECT. We're going to stick with the white bars because that's the brief pulse right unilateral ECT. So if you look at the white bars, you can see after 6 months, most kinds of memories, it turns out, actually improve, interestingly. And if you use the right unilateral, even the autobiographical, which is this last one, will improve. If you stick with the brief pulse or the sine wave, you may have, this is measuring amnesia, basically, retrograde amnesia. So this study was looking at, different kinds of ECT and which one works, has the least impact on memory. But even with the other kinds of ECT, people's memory, or what we would call thinking capabilities, actually improves after ECT. So what's happening here? Most cognitive problems are limited to the first 3 days after treatment. And it turns out after 15 days, processing speed, working memory, anterograde memory, and some aspects of executive functioning improve beyond the baseline functioning. This is a meta-analysis from an article in Biological Psychiatry. And I just want to say it in a different way so you can kind of understand what I'm saying. If you took 100 people who were so severely depressed that they were going to get ECT, for example, and then their memories are terrible at that point. There are also a lot of medications that can interfere with memory, but you're so depressed you can't focus. So memory is awful at that point. You give this 100 people ECT and then check 6 months later, some of them are going to say, oh, my memory is way better now than it was before. Probably not necessarily because of the ECT directly, but because they're not depressed. So when you're not depressed, your memory is just so much better. So what you see is patients who are not depressed 6 months later, their memory is really good. If they get depressed and have a relapse, or the ECT, they didn't get ECT in some of the studies, when they did the studies, your memory will still be bad because you are very depressed, basically. So the majority of patients described improved memory and cognitive functioning after treatment, which correlates with improved mood. So if you have improved mood, your memory is probably going to get better. If the ECT is working for you, it will work for your mood as well as your memory and cognitive functioning. But I would say this, that persistent memory deficits are rare beyond 6 months, but they do occur. Definitely I've met enough people, I've heard enough stories that, and I believe my patients, that people sometimes do say, hey, I've had some amnesia, or I've had some things I'm just not as sharp as I used to. I think it has to do with the ECT. My memory is not quite as good, or certain aspects of my memory is not as good, but my mood is fine. So that's something to be aware of. I think it's quite rare, but it does occur. So just want to be clear with everyone about that, and I try to be clear with everyone about that. So the bottom line is the cost-benefit analysis must be made on a case-by-case basis. It doesn't make sense to me to say, oh, we should ban ECT for everyone, but we have to make a cost-benefit analysis for each person, make sure it's the right thing for them. And just by the way, we generally use the right unilateral lead placement to start. This is what our anesthesiologists, by the way, we have a great team. It really is a team effort. These are what our anesthesiologists look like. Great bunch of guys, and women too, by the way. So how does ECT work? Our knowledge of ECT is very partial. Our knowledge of depression is I think we're still in the rudimentary phases of figuring out what causes depression. Depression itself is probably a grab bag term of things. There are a lot of people we diagnose with depression. Some of them have this treatment-resistant catatonic psychotic depression who get ECT and do really great. They're probably different, even though we call them depression and they have some sad mood and so forth. They're different from people who are depressed after you lose your spouse of many years, you feel really sad, you're crying. That means probably a different, I shouldn't say probably, that's a different disorder. It's a different thing than the kind of individual who gets ECT, who's been depressed for 2 years solid and, hearing voices and so forth. So I just want to be clear about that we're unclear, and our knowledge about ECT and depression itself is only partial at this point. I don't get into the slides of this, but this actually is some very interesting studies looking at how brain functions before and after depression and treatments for depression. Now, one of the things, ECT, as far as we know, doesn't cause brain damage directly, at least not how we do ECT now. When you do ECT on these poor rats, and then you do biopsies of their brain, autopsies of the rats, their hippocampus, which is a very important part of the brain for memory functioning, it gets bigger, which is thought to be a good thing. Your memory gets better after ECT. And in a small case series using these really high-tech MRI machines that can measure these things, you need a really good, powerful MRI machine. They had a small case series of 12 patients where they measured the hippocampal volume, and they showed that it got bigger for these individuals after the ECT. So that's kind of a good and reassuring kind of finding. It turns out that in Petri dish studies, so if you take nerve cells and grow them up on Petri dishes, and you give them electroconvulsive therapy or shot, you can't give it, it's not considered therapy, but if you give electricity in the same kind of way that we might give it for ECT, you can see that the brain cells actually do grow more. There's a proliferation of the neurons, the brain cells, and also their connections with each other. So in some ways, going back to Ladislav Meduna, who I showed in the very beginning of this presentation, he was right. It does cause changes in seizures do cause brain proliferation. They had rats who got ECT had a threefold increase in the number of new cells that they grew, and they reduced the expression of Sprouty2, which is a protein that inhibits the cell growth. This is what our ECT machine looks like. They're all kind of, there's only 2 companies that make ECT machines. They're not big companies. We buy these things, 10 years ago, and we don't have to buy another one, so it's not as if it's a big money-making thing. There's only about 100, my estimate is about 100, 150 ECT centers, so there's only about 100 of these machines out there. We only need to get a new one every 10 years or 15 years, so the numbers add up to being, these can't be very big companies, as you see. These are another picture of our recovery room. So let me just go into in the last 10 or 15 minutes here, go into the nitty-gritty of like what the treatment entails. This is a picture of a patient's socks, and she gave me permission to show this picture, by the way. She had these socks made up for when she comes into our ECT suite. We ask every patient who gets ECT whether they're thinking about hurting themselves or committing suicide, or if they have a plan to commit suicide, so she just had these socks made to answer that question, and then had the socks to remind us to do our timeout, make sure we're treating the right person. So kind of a good sense of humor in our patients. Okay, so what do we need to do before we get ECT? So we get a pre-treatment evaluation for general anesthesia. So just like any other procedure that requires general anesthesia, they go in our system. They go to our pre-anesthesia clinic run by our anesthesiologist, and they'll get they'll do a history and physical, take any required labs, or do an EKG if that's indicated, if that's needed. Certain medications must be stopped or decreased in advance. That's very important because we're trying to generate a seizure. Many psychiatric medications, such as Ativan or lorazepam, can suppress seizures. So you need to work with your psychiatrist and plan about the medications both before as well as after, as I mentioned earlier. ECT generally requires, and I like to say between 8 and 15 treatments. People often ask me how many treatments do we need to get. It really depends on how well the person's doing. If the person has done really well after 6 or 7 treatments, we won't keep going to 15 just to fill up the number, but we'll stop after a certain point. So we usually do them in our system. We do them Monday, Wednesdays, and Fridays. There are other bigger systems that are doing them, 6 days a week or whatever. But since we're small, we're just doing Monday, Wednesday, Fridays. I would say on average between 8 and 15 number of treatments are given. For each individual treatment, the patient is NPO, meaning the person can't eat anything after midnight, except maybe if they're taking medications with a small sip of water. In the morning, they come into an ambulatory surgical center. They're given an IV is put in, intravenous line is put in. They're put to sleep with methotrexate. So if there are any clinicians in the audience, Brevitol is a barbiturate medication, which is very short-acting, so the person's asleep for about 10 or 15 minutes. Succinylcholine is our muscle relaxant, so the person doesn't really move that much, even though they're having a seizure. The stimulus is given, which means we give a little electric stimulus, and it's called electric shock, and technically, I guess it meets the definition of a shock, but the machine delivers the stimulus in a very precise kind of a way that minimizes the amount of electricity to maximize the amount of efficacy to generate a seizure. And the seizure itself will last 30 to 120 seconds. It's rather anticlimactic to observe the seizure because the person is given a muscle relaxant, so they don't really move that much. After the seizure is over, the person awakens after about 5 or 10 minutes, They're taken to our PACU, which is the post-op area. And after about an hour or less, the patient is usually fully recovered. This is a picture of what it looks like to be hooked up. Of course, everyone has their gown on, but just for the sake of this picture, this is an individual who just has his underwear on. The picture is backwards for those of you who are clinicians. We have everything on the right foot and so forth, but this is where our machine is. They're all hooked up with the EKG machine. They have an IV line in. We have a blood pressure monitor. We have a pulse oximetry, so we know how much oxygen the person is getting. The person is not intubated. We just mass ventilate. Since they're asleep for so briefly, we don't have to put a tube down the person's throat. We just use a bag and ventilate the person while this is happening. And this is a picture of us. So I don't know if we're that much of an improvement about from the psychiatrist of yore, but this is what we look like. This is my mentor and colleague who I really want to thank a lot. His name is Stephen Hall. He began our ECT service, and he's the director. This is me. My wife would say I would need a haircut, so hopefully if any of you ever do see me, I'll have a better haircut. And that's really it. So let me just summarize. No antidepressant treatment is better than electroconvulsive therapy. Possible adverse reactions to ECT include headache, nausea, muscle aches, post-treatment confusion, and memory impairment. So I want to be clear with everyone that that's a possibility. Informed consent, and the procedure is actually pretty regulated by state law, much more than other medical procedures. The procedure is brief and typically requires 8 to 15 treatments. We do them 3 times a week, usually Monday, Wednesday, Friday, most places. ECT has a high rate of relapse without continuation of pharmacotherapy, meaning it's not a cure. You still have to be on medications after the ECT. And finally, this is what the view from our post-op area looks like. We have a great view of Golden Gate Park, and this is, I think this is University of San Francisco. And that's it. So I think we can take questions here. Oh, and I did make up a handout, Ashley, for people if they wanted one.
Okay, wonderful. Well, they can either, if you want to email that to me, I can distribute it, or they can just email you directly if you prefer that.
Let's do both. If they want to email me directly, that's fine. And if they want to get it from you, I don't know if there's a way you can post it, Ashley. That might be easier.
Yeah, we can definitely post it on our website.
Yeah, okay, here it is. I'm going to move it to my desktop, and I'll email it to you right now.
Wonderful, thank you, and thank you so much. This was very wonderful. Our first question is, have any studies been done on adolescents, and does this therapy work well for them?
So the question, the adolescent population is not well studied with ECT because most of the time adolescents are treated with other treatments first because to qualify as treatment-resistant depression, as most of you probably know, each would require 4 to 10 failed medication trials, and each trial takes several months, sometimes a year or two, to find out whether they're going to work or not. So there isn't that much known about adolescents. But there are adolescents who get ECT. It does seem to work with them just as well as it does with adults, in my personal experience. But I can't say for large numbers of people.
Thank you. Does the 24-hour consent process need to be repeated before each ECT session, or just the beginning of the set of sessions?
We interpret the law as for each series of sessions and every 30 days. So occasionally, if the timing is off from a course and the person's, say, getting like 15 treatments, they may run into the last few treatments we're going to need to re-up the consent, as it were. So we just reconsent the person after 30 days. That's kind of how we've interpreted the law, and it seems to make sense for us.
Thank you. Is ECT covered by insurance, or is it considered an alternative therapy? If so, what can one expect on average to pay for this type of treatment?
Well, I did some calculations about this a while ago, but ECT is a covered treatment by most insurance companies. Now, they can choose how much they want to cover it. I believe different policies have different plans about how much they will cover for your treatment. But it is considered a medically necessary treatment. Pretty much all the studies support its use, so no insurance company can really object to it saying it's an experimental treatment, or it doesn't work, or it's it's an alternative form of treatment. No, the studies are way too robust for insurance companies to refuse treatment. And in fact, they are happy to cover it because it often will save their person from being hospitalized longer or being really depressed for long periods of time. In the short run, and in the long run, it's cheaper to get ECT than to continue to have the person being so severely depressed. Even just talking about it from a financial perspective, let alone the personal suffering.
Yeah.
The cost of an ECT treatment, I get paid a little bit. I get paid a salary, but a little bit for my professional fee gets paid. The anesthesiologist gets paid, and then the facility also gets paid. I think the total fee Medicare will pay for each treatment is probably around $800 or $900 per treatment. So now that's the Medicare fee, and as you know, hospitals charge a lot more money than what Medicare is willing to pay. So if someone had to pay out of pocket, it gets to be really expensive because each treatment's like $1,500. That was my calculation in the past, $1,500 for all the fees, and then you have to get 8 to 15 of them, so it gets to be prohibitively expensive for people to pay for it on their own.
Does what about maintenance ECT? Does your center do that as well?
Oh, great question. So I had mentioned that there's a high rate of relapse after ECT. Maintenance ECT refers to the person actually feels pretty good, and we continue to do ECT. And we don't do it as frequently because the person's feeling pretty good. We might do it once a week, and then over time what we try to do is we try to taper it off so that we're getting the person down to maybe once a month would be better to do ECT. Now, having said that, everyone who gets ECT with us, pretty much everyone, we really try to have them, we try to stop the ECT so that they can go out and live their lives. But sometimes individuals begin to relapse, and ECT seems to be the only thing that really works for them. So we do have some individuals who seem to really benefit from just getting it once in a while, say once every 3 or 4 weeks. And these individuals also tend to be self-selected in the sense that they're the ones who are not going to have a lot of side effects. Because if you don't have any side effects with ECT, you don't mind getting it once a month. But if you have a lot of side effects, of course, you're not going to want. That's not going to be tolerable for the long run. We do maintenance ECT.
Okay. We have a comment. Thank you for this lecture. I've had several series of ECC. This is very helpful. Our next question is ECT mainly for the severely manic or severely depressed?
It's primarily for the severely depressed individual. The severely manic individual, there are usually other medications that we can try. So we usually don't use ECT for the really manic person. Now, there are some individuals who are undergoing what we call a mixed episode, meaning they have mania and depression at the same time. In that situation, sometimes ECT can be helpful. Still, I think in general we will try to go with mood stabilizers such as lithium or Depakote, and then the atypical antipsychotics for mania or mixed episodes. But if they don't work or they're kind of working, sometimes ECT can be helpful as an augmentation for those.
Thank you. Another comment. I've had ECT over 13 years ago with 8 series, and it was very successful for me.
Thank you for that comment.
How frequently have you come across cardiac arrhythmia during an ECT session, and how have you dealt with those instances?
I think we've only had occasional cardiac arrhythmias, and some of them are more worrisome than others. So, for example, during the ECT, a lot of neurotransmitters are released. The neurotransmitters affect, all sorts of things in the body, and a lot of things are being released. The heart rate and blood pressure go up acutely during and right after ECT for, several minutes after the ECT sometimes. So that can sometimes trigger cardiac arrhythmias. It's pretty rare, I would have to say. Maybe in the last year we've had one person, or in the last 2 years we've had one person who had an arrhythmia. We have an anesthesiologist right there, and the person is being monitored continuously with an EKG, so we can deal with those things as they occur. Now, there are different kinds of arrhythmias. I'm not a cardiologist, but the arrhythmias we generally face, or at least the ones I've faced in my relatively short career of doing ECT, which is almost 9 or 10 years, almost 10 years now, have been things like relatively more benign arrhythmias. People may have had these arrhythmias in the past and might have them again. So that's my answer.
Thank you. You talked about comparing ECT to pharmacotherapy. What about ECT to psychotherapy, such as CBT or other talk therapy treatments?
I don't think they've been compared directly. It would be hard to do such a study, I would think. And also, it's pretty clear, as I mentioned earlier, depression is kind of a heterogeneous kind of thing. A lot of times, the patients who have come to us, it's pretty clear, for example, if you can't talk or you can't focus, that psychotherapy is not going to work that well. I'd also say that many of the individuals who have come to us who've had ECT have also had psychotherapy before. But to be quite honest, there haven't been any direct head-to-head comparisons. But it would be comparing, I believe, a very different patient population. So the patient population who were getting ECT, many of them couldn't engage in psychotherapy. And many patients who could engage and do psychotherapy, probably we shouldn't do ECT with them. We should give the psychotherapy a try first.
Many people who suffer from depression also deal with anxiety. Does ECT have any positive effect on anxiety?
Um, it's hard to say. Certain individuals seem to do really well. Their anxiety seems to melt away with the ECT. Others, and it seems like if their anxiety disorder is more primary, and it's hard to define that term, but if the anxiety is more primary, then the ECT does not work that well for that. So things like panic disorder and stuff like that, it doesn't seem to work that well for. But it does work really well for if the person has depression and panic disorder, that the depression will be better. And then sometimes, getting back to the other question, the person will still be left with a panic disorder, but now they're not as depressed. They can go and get psychotherapy for their panic disorder now that they're not, severely depressed.
Great. We have time for a couple more questions. What is your opinion of ECT during pregnancy?
ECT during pregnancy is very commonly done. We don't do it that much at our center. I think partly because most individuals who are depressed while they're pregnant really try to just gut it out and hopefully get through the pregnancy. It's a relatively time-limited period. But ECT is very good for the pregnant individual in the sense that it's very localized. We deliver the treatment to the brain, and so the developing fetus, while they may get a very brief bit of anesthesia from the anesthesiologist, it's probably in some ways more controlled and probably safer than having an antidepressant medication, which is in your system the whole time of the pregnancy.
Okay, thank you. And can you speak to the difference between TMS, which, if you aren't aware, to the listeners, it's transcranial magnetic stimulation, versus ECT?
Now, Ashley, can people still see my screen?
They can.
I'll try to pull up a little slide here if I can. I have a couple slides on TMS, but basically TMS is using strong magnetic currents to generate these relatively weak, see if this is a picture of this, nope, that's not it, to generate a relatively weak electric current in the brain. So I believe TMS is helpful, but it's not, it's for a different patient population than the ECT population. So if you're going to get TMS, it works really well, I think, for more of the run-of-the-mill depression, as it were, but it's not for treatment-resistant depression. TMS also is a series of treatments that people have to go through, and I'm just slide here, have to go through kind of like ECT, but it's every day, Monday through Friday for like 4 weeks. So I'll pull up my slide if there aren't any more questions.
Just one last question. Someone specifically asked where the best place was in Massachusetts to have ECT done, but it might be helpful if other people are not in California or near you, if there's kind of a website or a directory where people can find out where this treatment, where they can receive this treatment.
Oh, that's a great idea, Ashley. The Association for Convulsive Therapy, if you Google that, has a listing, or I think you can send them an email inquiry for ECT. I would say this, though. ECT is a very standardized procedure. So it's reasonable to go and visit with the ECT psychiatrist. Not reasonable, you should before you get ECT. But it's very standardized. So we all have pretty much, there's only 2 companies that make the machines. We all pretty much do it pretty much the same. So I've talked with people from Massachusetts, from Atlanta, from Washington State, from Kansas. Anyone who does ECT pretty much does it the same way. It's very uniform. So I'd like to reassure the audience in general that it's pretty standardized. The only slight difference, and I I think there's a room for honest difference of opinion here is whether you start with bilateral or whether you start with unilateral. But it's pretty consistent. So I think if you meet with the psychiatrist and you feel like they're competent, that would be the most important thing.
Thank you for answering that.
I'm still looking for my slide here about TMS. I may not be able to find it.
Okay, if not, maybe if you want to send me maybe one slide, or if that's possible, and I can forward that on if people are interested.
Definitely.
Okay, wonderful. Well, thank you so much. This was really a great source of information that you have shared with all of us today, and we really appreciate all your time.
Thank you, Ashley. Thank you, everyone.
Take care. Bye-bye.
Bye-bye.